We just had some work to do here. Thank you so much for inviting me here. I am, as a clinician, in absolute awe of the work that you do, and so appreciative of the work that you do for our patients. So I'm a bit out of my element with this crowd, so I hope you'll understand. But I hope I can bring just a little bit of a different perspective for you. So I'm going to be talking about our Silent Genomes Project, which is a Genome Canada, CHR, Genome BC funded project that we've been working on really since 2017, and how we're trying to build the path to equitable genomic care for Indigenous patients. And for this one talk, it's about one variant at a time. So I acknowledge with respect the Songhees, Esquimalt, Musanish, and Coast Salish people on whose traditional territories I have the privilege to live, work, and play. And those are my morning walks and evening walks. And I also acknowledge the Gananoque Mohawk Nation, recognized as the custodians of the lands and waters on which we gather here today. So I'll be walking you through our some of the path that we really need to get through in order to achieve equitable genomic care. So we need to understand the barriers in access to diagnosis. We need to be able to operationalize, not just talk about it, but operationalize Indigenous involvement partnership in this project we will tell you about. Indigenous guidance needs to be, and governance needs to be, a sustainable part of our background variant library. And I'm going to show you our first steps, the first phase of how the Indigenous background variant library is being built and led by Dr. Wyeth Wasserman, who would have preferred to be here but could not because of family reasons. For everyone in this crowd, you are probably very aware that Indigenous populations make up 5% of our population. There are 634 First Nations communities depicted in green dots throughout Canada, throughout the north, all the way from the north right down to the south. Inuit communities depicted in red, and Métis communities, yes, depicted in blue. So although there is great diversity within and between, in common, there are great challenges to accessing healthcare, especially specialty care, including genetics and genomics. I just want to remind you that in Canada, most, probably 90% of the population actually lives within about 150 kilometers from the US border. So as you can see, the dispersion is quite different for our Indigenous populations of Canada. So some of our genomic barriers have to do with the remoteness of many communities, but also, staffing, poor access to clinical expertise at the point of care to recognize genetic diseases, and also referrals that might not be made, things that are not obvious, when there's a rare disease. But the additional barriers, even when people are close to tertiary centers, are unfortunate racism in the healthcare system. Sometimes healthcare providers see the social determinants of health as the number one cause of everything and forget that even in all populations, there are genetic conditions. There's a long history of research transgression, so that affects actual trust. And as we know, and as is discussed over and over again, Indigenous populations are not well represented in variant reference databases, which is a barrier. It's a barrier to diagnosis. So this is a great slide, but it's GWAS study just showing how we're doing better with diversity. But still, as we continue to do better, at the end of that slide there, seeing those colors come up, what we're seeing is that the actual gap gets bigger and bigger because there is more and more information about European populations, even though there's increasing diversity. And this is right until quite recent. So many of you will know that version 4 of GNOMAD, or the reference database that we use, especially in clinical medicine. is now quite large. There are a huge number of individuals that have been added, including 138,000 individuals of non-European genetic ancestry. So there are some Indigenous people within there, especially under the admixed American category. I saw Hawaiian Native, I saw other Indigenous populations there, Native American. There's remaining individuals where it's not clear where they would fit. So it is possible, but the actual numbers and the quantity are really not clear there. They're not identified as. And this actually, the reason, so why is that? Why is there so few? And some of those reasons are just that Indigenous populations, Indigenous people may not participate in research to the same extent that European populations will. I would say probably we're learning that the number one reason for that is that people are not being asked, not that they're deciding against it, but there's an assumption that they will decide against it, so they're not being asked. But then even when they are asked, then there is concern, what is going to happen to my data? It's not just about previous genetic and genomic studies, it's about our history in Canada of the way that, federal government experiments were done on Indigenous people without consent. Shameful research. I always bring up that top left-hand corner one. I mean, it's just absolutely shocking to think that pediatricians, around the time that my mother was a child, pediatricians were starving Indigenous kids. My mother's family, they were immigrant Irish. The most important thing was to have food on the table. So if they knew that, why did federal government not think that children should have been fed? So these are the kinds of histories that people remember. They don't forget that. And so there is concern that somehow information can be used against them. So there are other reasons why specifically genetics and genomics research may not be of interest. Genetic cause may be considered stigmatizing. It depends on what the focus of the actual study is. Very early studies were, done on socially stigmatizing conditions. And then again, data may be used for exploitative purposes. I think the biggest issue is that the data may be used to benefit mainstream populations, and those that have the most disparity, the Indigenous populations, they themselves who are participating may not benefit. So that's a real key factor here. But Indigenous people around the world, including those in Canada, one of these articles was first authored by Nadine Caron, really have stood out and said, we need to do things different. We want to do this, but we want to do things differently. And sometimes we want to be doing it ourselves, or at least be co-designing and co-implementing at the same time. So there is a lot of great conversations that are going on and things are changing. This is not new. Francis and I spoke about this, I think, in 2006, about the importance of, what it means with open data. I first learned in 1994 at a circumpolar conference. None of these concepts are brand new. This has been going on for a long time. We just take a long time to catch up and implement into our mainstream science. So 1 in 14 people have a rare disease, and that's some of the work, bioinformatics work that was done through our Silent Genomes team. And a large proportion of those will have a genetic basis. Even though there are social determinants of health that sometimes override what people are seeing in Indigenous populations, there's no reason to think that Indigenous populations, Indigenous people have less in the way of genetic conditions than anyone else. So if you estimate our population, at least 100,000 Indigenous people will be affected. So what do we do about that? And where do we start? So we start with I guess, with a postdoc of WIAS, Maya Terelic-Gravik, who was carrying out rare disease studies at the BC Children's Hospital. And she went to Wyeth and said, these variants, I'm not able to interpret them. There's an issue here. Every time it's a First Nations patient or an Indigenous patient, I'm having a lot more trouble with the analysis. So Wyeth listened and I started to think, how can we do something about this? So for all of you who are postdocs out there, speak to your your mentors, and this can be a start of something really important. So Wyeth knew about a Genome Canada initiative, and he thought this might be an opportunity to at least start to build that equity one variant at a time by building reference data. So in 2017, a year before the application was to be funded, we started talking. He actually called me. I called Nadine Caron, Jeff Redding, other Indigenous scholars, and we started talking to our local First Nations Health Authority, the Assembly of First Nation, Inuit Taperet, Kanatami, and Métis National Council over that year as we were building that application and going through our 5 different internal reviews to be able to get to the application stage. We were incredibly honored to be funded, and those are the funders, many of them in addition to Genome Canada, Genome BC, as well as the CHR. And from 2018 to 2024, the first phase of the Silent Genomes Project. We're in an extension currently, a non-cost extension. But during that time, we were able to build a governance model for the use of Indigenous genomic data. We were able to offer genomic diagnosis across Canada to Indigenous children who did not have a diagnosis but had a likely genetic condition. And we went beyond the planning. We went to the first phase of building an Indigenous background variant library. And we always have an economic aspect to this. Dr. Dean Rieger is leading that, and I won't be talking about that. He does amazing work and something to be listened to as he's been able to get the data to understand better where the disparity lies. So our activities, we call them activities, were first Inuit, First Nations, Inuit, and Métis engagement, governance, capacity building all together. And Dr. Nadine Caron was leading that. In fact, we've eliminated that as a distinct activity. It is now absorbed into every aspect. The intent was always that it was going to be continually, interconnected. And I can honestly say it is. There are no silos. This is all interconnected as we go, which was the goal. And as you can see, Dr. Maya Tyrella Gravik is now an associate professor actually at the University of Calgary, leading her own lab there. And she has been helping us with model organism and bioinformatics interpretation for our study. And Dr. Anna Lehman is the lead for she's a clinical genomicist, lead for precision diagnosis right across the country. And Wyeth, of course, his team was really the one to plan and to start building the IBVL. So in order to be able to do this, we needed a lot of Indigenous voices. Nadine is stretched. She's involved in a lot, and we're very, very grateful that she's part of our project. And we also need others who are involved in genomics and have expertise. So we actually reached out to our colleagues around the world, New Zealand, Australia, and the United States, and Hawaii. I was kind of separate them. And we were able to bring on a really incredible group of people to advise us along the way, led by Miley Tawali, who is continuing to lead this part of it. So they've been able to advise us at the drop of a hat. We have a question, they gather, we talk about what their experiences are. And then Wyeth went off to actually do a sabbatical with Phil Wilcox and his team as they're building their very own in New Zealand. So it's been a really important collaboration with all these folks. We also need to hear from our community members. So this was just a photo of our first gathering once we were funded to launch. So we talked about what was being presented. We wanted to hear from community members and organizational leaders about how they would like to see things done. So that was, and that's something that we never stop talking about. We call it the continuous conversation. And so this is really about making sure that our Indigenous colleagues are collaborators in the same way we have scientific collaborators. It's just hand in hand as we go along. I would love to talk for 45 minutes about the precision diagnosis study. I'm extremely proud of the of what happened over the last 6 years with our national clinical network and how sites were developed in every genetics unit across the country. 11 out of 15 were able to achieve ethics approval. Reasons for the others not achieving it is a topic of a whole other conversation. But in the meantime, we were able to offer diagnosis from right across the country. And this was also an important proof of principle for the Indigenous background variant library and why it was needed. So from at least 84 families with 96 affected individuals, nearly 50% of the variants could be interpreted better if an accurate population allele frequencies were available. I can't tell you the number of times, because I'm also on this team, how we would sit in an interpretation meeting and we would be thinking that a certain variant is so compelling that we need to get those model organism study, only to find out after that some internal reference database showed that in fact there are homozygotes that don't have this phenotype. This needs to happen. It needs to happen for efficiency and to be able to provide the diagnosis. We continue to do functional studies on candidate genes, a couple of really amazing discoveries that were made. And again, Maya's lab is leading a lot of that. And we've also had some big population impacts. So certain variants were discovered, for instance, the DNH11, that actually led to the diagnosis of 7 other individuals in Nunavut. And as well, we're now in the midst of doing population studies to determine if newborn screening might be necessary. So although many variants can be interpreted as diagnostic without an IBVL, their uncertainty remains with very compelling variants, and this is very important. So on to the Indigenous background variant library development. So in order to be able to start this, given so much of the work that I've done over the last 30 years, I was able to know of the Canadian Alliance for Healthy Hearts and Minds. I'm one of the PIs for that. Sonia Nand leads that project. That is the First Nations arm of that. There are First Nations communities right across the country who have their own research platforms. They have fully consented to future research, mainly for cardiovascular disease, cancer, diabetes. But the samples, fully consented samples, were stored. So what that meant is that we could start conversations with some of these communities to say, would it be okay to use those stored samples for this purpose? And that was literally a 5-year discussion. And these are people that I've worked with since 2013. So this is not a new relationship we're building. So these were really important discussions, monthly discussions, to be able to see if they would be willing. And that was something that we learned was really helpful in the end. We also worked with really excellent co-investigators to help plan our library across the country to make sure it would be robust. So Simon Gravel, Ripan Malley, and then of course Wyeth's whole bioinformatics team here in this group is it really have played a major role in the background as we were starting to develop. The two community genetic coordinators at the top there were absolutely instrumental in speaking and connecting with the communities. So in 2019, both Brittany Morgan and I traveled across the country to 6 communities at least twice. So these were communities, again, that had been part of the Canadian Alliance for Healthy Hearts and Minds and had stored samples and had full consent. And we talked to their tribal councils, we talked to their communities, we had big dinners, and we said, is it okay to use it for this purpose? And they basically said, we're thinking about it. So the process is one that is not just a transfer of sample. It has many, many steps beforehand. So most studies start with this transfer of biobank samples. So we started with the education, information, the two-way education, what's important to them. Are we getting it? Are we explaining it well enough? And then we knew that we could not get anything transferred until we had an appropriate governance process. And this is why it's hugely important to go to this step. So after that, we were basically on hold for the next 4 years. Until in 2020, October 2020, pandemic going on, we were able to start monthly Zoom calls with our steering committee, who were largely community members from across the country who had lived experience of genetic conditions. There were also Indigenous organizations such as the Métis National Council, our First Nations Health Authority, and those that were connected to those alliance communities that may be interested in allowing their samples to be used. Again, these are healthy individuals. That's why it was appealing to have these cohort samples transferred. We had a number of tools that we could use, the rights and safe governance tools, we're calling this. But in fact, for the purpose of this conversation, it really is important to understand the United Nations Declaration of the Rights of Indigenous People, which has been adopted by Canada and British Columbia, in particular, where it's been enacted into law. And several of these articles are about self-determination, data sovereignty, hugely important, decision-making, free, prior, informed consent. And in 2018, the first care principles were then published, and we also had Canadian involvement in that, and that was the Global Indigenous Data Alliance. These care principles were in response to the FAIR principles, which all of you should know about, which are findable, accessible, interoperable, and reusable. And of course, the care principles brings into the Indigenous perspective of collective benefit. We're not doing this so that we don't get care again. Authority to control, and that's the data sovereignty piece, as well as responsibility and ethics. And each of these has several components. Since 2018, there have been several publications on this. Really important to consider it as a concept alongside with FAIR when we're talking about this, not just here, but around the world. So the steering committee, wow, did they do a lot of work, and are they continuing to do a lot of work? And they have been meeting every month since October 2020, with very few exceptions. We've also now started to have some in-person meetings. And there are many aspects about this. What do we do if somebody wants research? So this is largely about developing a variant database that is for clinical purposes, but might be used for researchers, maybe research that is priority to them, that always has been a priority to them. So how does that happen? Under what circumstances? How can all the care principles be implemented if we are doing this? One of the most important aspects of this was the initiation of was actually the process for clinical variant release. This took more than a year to actually get established, and I'm going to walk you through that. So I think I have 15 more, let's see, about 10 more minutes, 10 more minutes. So I want to explain that clearly and also bring you to the point to where we are with the actual sequencing. So a whole spectrum of options were presented. After a year, it was decided that it would be a registered, there would be registration and access. So not every time a variant was being asked for, but any new person that was actually asking for access, this has to be approved by a Silent Genomes team member. This will have a bit of a delay, and we take that into consideration because it was where all the steering committee felt they could live with this as long as there was registration. And with that goes actually a statement of context. So the statement of context says, I'm only using this for clinical purposes. Remember, research would be under a different category. I'm not going to publish this data, without permission. All of that is in the statement of context. And I have read the resource document, understanding why Indigenous data sovereignty is important. And then the registration is in place. And then Then the statement of context again, and you have to initialize that you're actually going to go ahead with that. The interface was built with this then to be released after that purpose. And with this, it's actually a beautiful interface, the IBVL frequency, as well as Nomad, and of course has a direct link to many of the other sites that are important for us in clinical diagnosis. Now, this reference is reference HG37. We are also working on HG38, just to let you know. With that in place, with the governance in place, that was last summer, then 596 samples were approved for transfer. So this is phase 1 of the IBVL. Okay, we had to go on to sequencing, and some of the very first data that was generated here showed very high quality sequence data. That was Genome BC. We'll give them credit for that. And then, of course, what we wanted to make sure is that we had the coverage that we needed. And as you can see, we've got at least 30x coverage in most of these genomes, at least. So it's actually even better than what we thought. And then Selene Corriard, one of Wyeth's postdocs, and Wyeth developed the software, the open source software using Nextflow to be able to, as a pipeline, to be able to determine the mitochondrial variants, single nucleotide variants, and structural variants. And that was first tested on 100 publicly available genomes and is now being used not only by us, but also by the New Zealand Variome. We're also working, and this is a really important piece right now, we're working very hard to assess the utility of the first stage of the IBVL within Activity 2. So Activity 2, the genomic diagnosis, this is a great place to say with those variants, with the IBVL that we have. Now, I told you it's 596 samples across Canada. We have major gaps, geographic gaps. We have nothing in the Maritimes. We have nothing in Ontario. We have very good West Coast coverage. So we've got gaps. So we don't know how much of this is going to be covered. So our patients from across the country are a good way to say where we might be having gaps. I'm starting to use it as a clinician. I said that I see patients with rare diseases. I will be using it. Our colleagues in Victoria use it. And right now it's not open for everyone to be using it on the web, but it will be by October. In the meantime, our team, Dr. Anna Lehman, who's our Activity 2 lead clinical genomicist, with her graduate student, Joanne Speakman. Joanne is Dene from Northwest Territories. She is actually leading the utility studies, and I'm going to walk you through some of her results that she is just working on now, and she is excited to share this. She's somewhere online. So she's here with us, and hopefully we'll be presenting all of this for the first time at a conference in November. To show you some of the work, they actually, what they did was they compared a random sample from the UK Biobank to look at the percentage of variants after filtration using Nomad version 4. We wanted to use the most up-to-date version. And as you can see, even though a very, like a small difference in variants can really make a difference in your amount of work, what we see, especially with the autosomal dominant, is quite a huge difference in what we're seeing between our Silent Genomes Project versus the UK Biobank, with the number of variants that are remaining, number of rare variants that are remaining after filtering. So we also, they have gone through, I'm going to slow down a little bit so I can explain this really well. This is, again, only using the Silent Genomes Project cohort. So about 105 individuals here that are Indigenous. And the first filtering occurred using Nomad version 4, and that is is it magenta, the color? it's yeah, the color on the left, yes. So that, as you can see, there were probably around 320, average of 325 rare variants. And as you can see, because these are violin plots, you can see that a large number of individuals had this amount left. In-house, they have a very small consented in-house variant library based on their Activity 2, only 38 patients or 38 participants. And what you can see here is that there was quite a substantial drop, even with that small number. So it's quite remarkable, because we know a lot of populations are not, well represented. And then we were thrilled to see the difference with the IBVL and how it was dropped. So this is even with very little coverage and big gaps across the country, we're seeing a difference here. So this one was also mitochondrial, and this was something that was predicted, that we would hardly need any participants to be able to bring the rare variants and mitochondrial variants down. And this was absolutely shown with Nomad. Oh, that's a Nomad version 3, not 4. I think I put in the wrong slide here. But in fact, with the in-house library and with the IBVL, basically it was brought down to 0. Okay. Oh, no, I guess Nomad version 3 is the only one that was used for this purpose. So that's why. Sorry, forgot about that. Anyway, so I think this is very impressive. Joanne's work is great. She's loving this kind of work. We're not sure that there are other Indigenous trainees that are doing this kind of work, but we're really happy to see her blazing this trail. So when it comes to equity and access, this is a start. Sustainability is essential. We will be part of with the governance model, the Pan-Canadian Genomic Library, with the same governance model. Sustainability is important. That's why it was important to be part of that. Okay, and expanding is essential. So these are just a few of the faces. There are many, many more. Our logo depicts all 3 Indigenous peoples of Canada. And a reminder that this is, from 2016, a complex web of historical, cultural, scientific, and logistic factors is sustaining an embarrassing bias in genomics. Before precision medicine takes hold in clinical practice, we must correct its course, and this is what we're trying to do. So I'm happy to take questions. Hi.
I'm Mary Jo Anderson from Northeastern University, also a member of Mohawk Nation. Thank you for acknowledging our territory. Traditionally, our people never observed international boundaries. Wouldn't it be good to do this for all of North America? But you have gaps in the Maritimes, but we have related people in the U.S., for example.
This the web-based version will be available to all. So the information, we know the Canadian information will be important for those that are below the border, the American border. So this will be available on a patient-by-patient basis. This would be amazing to do it and to be building it from other world populations without borders. I think that's a great suggestion. Yeah, thank you.
Hi. So we're part of a cancer institute, and as part of that, we generate clinical reports for cancer patients.
Yes.
Our interpreters, as opposed to our clinical geneticists, don't necessarily know the ethnicity of the individual that we're diagnosing because it's considered PHI. So how can we take care while not necessarily knowing the ethnicity of our patient, especially considering Guillaume Burke's presentation this morning, where it's really emphasized it's very important that all of these populations have representation in our reference. Do you have any ideas for that?
It's a great question. I actually just met with some of the folks from the Marathon of Hope to talk about whether the IBVL, whether there can be an agreement with the IBVLs, because we know that there are Indigenous people that are affected with cancer, and some of the sequencing that has been done, it would be beneficial to understand better the frequency of the variants that they're finding. So that's something I'm bringing up to the steering committee actually on Tuesday. So we're hoping there's going to be an agreement so that that can be used on a clinical basis, even without knowing whether individuals are Indigenous or not. Okay.
Hi. I was at a Western Pacific meeting of WHO, met Maui, and he's still struggling to get acceptance from the people who don't want to part with their ancestry.
Yes.
So I would like to know what kind of ethics documents and governance documents you have, and I will contact you later, because we are trying to build this for all the native populations in the Western Pacific region.
Yeah, it's a great question. I think that from a cultural perspective, it is very difficult sometimes. And I think the only thing we can continue doing is building the protection, the comfort, and the respect that some people want to call this, they want, instead of calling it silent genomes, they want to call it sacred genomes, because they want that to be.
That would be wonderful, because Alex Brown, I think it's related to this lady, but he told me that he has the same problem in Australia.
So he's actually part of our team now,
Yes,
and
yes.
and that's his sister Nyari. Yeah. So thank you for that.
Thank you, Laura. Great talk. I think one of your slides sort of alludes to this, but I saw earlier slides where you had like African variants, and within Africa, there is so much variation.
Yes.
And then, so my question is, how much variation is there within the indigenous population? Is that widespread, or is there some bottleneck?
Yeah, it's a great question. I don't, I can't say that we've actually looked at that. And I think that we are seeing less, I know, with Greenlandic populations. And is there anybody here from Greenland? Because some of the work that they've done has shown that there is less variation there, and we would expect something like that as you continue to go from west to east, there's going to be less and less variation because of the bottleneck effects. You're right. And we have not looked at that at all in our. We don't have enough samples. There are some ideas of whether we have the same number of variants that we would expect otherwise, but we've not actually looked at it from a scale. But we will need to be doing calculations to determine how well have we actually looked at this data in depth to be sure that we have enough variation that we're capturing it. So there are going to have to be calculations that show that with the new samples, how much more a variation is achieved. Yeah. And 2 minutes. Yeah. Thanks, Kat. I can't believe I'm on time. Like I never am. Okay. So hi, Fiona.
Thank
Nice to
you.
meet you in person.
Yeah, it's a real pleasure. I have to say thank you. This is a very relevant talk to this meeting. You were talking at the beginning about how much this would be appropriate, but it's fantastic. Thank you. So yeah, I'm Fiona Brinkman at Simon Fraser University in BC, and we are very interested in improving monitoring of pathogens and other microbes in water.
Yes.
And because of the focus on water, we're using a sort of Indigenous partnered approach. So we've been reaching out to different groups. And one thing that struck me here was I didn't see the First Nations Information Governance Center mentioned.
Yes.
And I'm wondering, what's your relationship with them?
So in fact, they're arm's length from AFN, but they are connected to AFN, and we invited them from the beginning to be part of this. And actually they, at that time, decided against it, but we've been keeping in touch with them. We actually discuss all of this with them. And they do have a grant that's actually overlapping this. So we're working with them, discussing it, meeting with them and talking. So yeah. But they're not governing what we're doing. They're just, it's a matter of sort of us sharing information.
That's really good. I think that's important. Just, keep connections and see how things develop.
Yeah, good question. Thank you. Okay. So